Good afternoon. Esteemed guests, dear colleagues and valued partners. It is my privilege as the Clinic Operation Manager to welcome you to our clinical meeting for April 2025. I wish to express my deepest gratitude to Dr. Shankar Srinivas Kuchibatla, the founder of Open Minds Group, our esteemed CEO and Medical Director, for his visionary leadership, which continues to inspire and drive this initiative forward. A special thank you goes to our valued guests. Your presence today reflects the strong partnership that fuel our commitment to delivering healthcare excellence. Today, we have a great honor to welcome our special guest, Madam Sheikha Dahahri, a member of the International Spiritual Council for Transforming Humanity. Madam Sheikha, thank you very much for joining us today. I would like to express my sincere thanks to Dr. Anamika Vajpeyi, sorry. Our dedicated clinical psychologist, who will share her very valuable insight during the presentation today. Without further ado, I invite Dr. Anamika to begin the session.
So today's presentation is basically going to talk about the future of mental health and how we can actually apply AI, digital phenotyping, and other measures to make the mental health more accessible to everybody, make it easier to detect the mental health issues in advance, and to provide preventative health care in addition to follow up with existing clinical counseling, psychotherapy, and other measures that we are taking to heal people. So that's why I called it Predict, Prevent, and Personalize. All right, so first of all, somebody was telling me we were Googling what is phenotyping because it sounds like something very extraordinary, but I think a lot of us would be doing it already. How many of you are wearing an Apple Watch right now? Anybody? Yeah, see, so you're doing phenotyping. Phenotyping is basically doing moment by moment real-time data analysis, a collection and analysis by using a personal digital device. Either it's a phone, it could be a ring, it could be a band, various kind of devices available. But primarily smartphones and other wearables are more common, which we all use. This term was coined by Dr. Professor O'Neill, who works at Harvard. Even currently, he's doing some further research on the same trajectory, trying to understand how to improve AI's contribution to mental health. And how we do it is through actigraphy. So this is basically a non-invasive method. Again, those of us who have ever used a smartphone to measure a heartbeat or pulse rate or any other sleep patterns, how many of you get YouTube alerts saying sleep time? Right? I think everybody can relate to that. So all that is done through actigraphy, where we are using devices to understand our sleep patterns, to understand physical activity, circadian rhythm, a lot of other things. How the data is tracked, these are the most common one. Advanced intuitive AI can actually go to a deeper level. But I'm just trying to talk about the basic stuff which easily available devices can track: sleep pattern, typing speed, texting frequency, GPS movement, app switching behavior. App switching behavior also relates to restlessness and distractibility, which happens when we are not able to use the app. There was an outage on of WhatsApp a couple of years back, a complete outage. I don't know how many of you remember. The amount of people who actually had an anxiety-like experience during that time was surprising. Whether it was FOMO, whether it was just a constant need to be in touch for various reasons, this feeling is directly related to app switching behavior. Voice tone and pauses is another way to track data, and I'll come to that, how people who are experiencing depressive episodes might be having a different voice pattern than those who are not. Facial expression and gaze, I think we all know that eye tracking is pretty common these days. Yeah. So what are the digital signatures of mental health condition? People who are, and all of this is referenced there, so you can look up the research if you would like to. So depression, digital signature, reduced mobility. Like for instance, fewer GPS location changes means a person is not really getting out of the bed, getting out of the house, doing what they need to do. So reduced functionality can be assessed by this. Decreased texting and calling. We know isolation is quite common in people who are living with depression, and delayed wake times because they sleep late and then they wake up late. Anxiety, frequent app switching, disrupted sleep, high variables in phone use patterns are commonly seen in people who are living with anxiety. Now, I just want to caution that these are not diagnostic criteria for this. These are just indicators of some people who would be tracked and would have these kind of mental health conditions, right? Bipolar, increased nighttime phone activity, sudden spikes in messaging and then slump, right? Movement patterns during manic phase might increase. So if the GPS tracker is on their body, then you can see that they are moving around quite a lot. Schizophrenia, disorganized typing behavior, decreased mobility and communication, reduced voice prosody and intonation. All this is seen in schizophrenia. And as I said, I've already referenced, so in case anybody wants to go and read more about it. I wanted us to have some view of what the research has to say, because then helps us ground whatever we are seeing into real-time research and then imbibe it into evidence-based practice that we want to do. There was a research, this is one of the earliest researches on this, so that's why I chose this one. It was done in 2017, as you might notice. And bear in mind that AI has moved many folds since then. So this is literally emergent AI that we are talking about in this study. Delivering cognitive behavioral therapy to young adults with symptoms of depression and anxiety using a fully automated conversational agent. In this case, they had used Wobot. Wobot was prepared by Stanford University and they are still using it. It's available. I'll come back to that again. And basically what they did was they used Wobot as a accessory to provide mental health services, right? So it was done on a limited sample, 70 college students, 18 to 28 years of age, usually digital natives, early adopters of AI, right? So found it easy to use this. And then randomized control trials were done. And what they found was, let me go to the result. So this is what Wobot did. They did daily check-in, 5 to 10 minutes of conversational sessions happened. CBT tools that were used were cognitive restructuring, mood tracking, and behavioral activation, in addition to other kind of journaling and other things were also used in unsynchronized time. And NLP responses, empathetic, pre-programmed, because remember, this is not a conscious AI, so everything was pre-programmed. So if this was to be repeated today, we'll find even better results, right? And then identifying challenging automatic thoughts, gratitude journaling, mindfulness, all that was used by AI, right? And the indicators to us understand the mental health difference between a control group and experimental group was PHQ-9 and GAD-7, which were administered pre and post administration of Wobot as a therapeutic tool for this particular sample. What did we find out? Reduced depression. So Wobot group showed greater symptom reduction than the control group, which was not using Wobot. They were using other techniques, journaling and other things. Higher engagement rate was noticed. Participants reported more emotional awareness and interaction because the tool was easily, readily available 24/7, which psychologist is available 24/7, right? So easy access. No harm was reported. And low threshold support, it acted as an accessible mental health ally, and that's how it was promoted also, not as a therapist, right? So this was like a support tool. And then, of course, help-seeking behavior increased. People felt it was easy, the sample felt it was easy to access the services, and micro-interventions were done on a regular basis without interruption. And we know how difficult it is for us to follow with the patients, ensure that they are in the clinic, for the follow-ups and so on and so forth. So that was kind of eliminated to some degree. The limitations was this was only for 2 weeks, so we don't know the long-term implication of this and how long people would be readily using this. Only 70 participants, so sample size was pretty limited and also restricted, so there was a bit of a bias if we see that. And limited demographics because they were literally young adults, so we don't know how older adults would perhaps have their own restrictions or barriers to use it. Another comparatively recent study, 2018, Harvard Medical School, what they did was they tried to study the feasibility of digital phenotyping to track symptoms and relapse of patients who are at risk of schizophrenia. So they used smartphones this time. Last time we used Wobot to collect the real-time data. The study shows that participants would engage consistently with both passive and active data collection, like there were surveys and there were sensors. So sensors is active and surveys were passive. Behavioral signals such as reduced mobility and communication predicted worsening symptoms. So they could find that early on, and early signs of relapse in the patients who have shown recovery. Proved that digital phenotyping is practical and acceptable tool for continuous symptom monitoring in psychosis. And so, of course, it's non-intrusive, it is an early on warning system, and it improves the care that we can provide to the patients. Another study done in 2020 by Mayer et al., remember the COVID times, right? Such restrictions were implied all over the world, and therapists were not readily available. It took a huge leap. I was, heading a program then on counseling, and it was a huge leap for us to now understand how to do work placements for students. They were seeing clients before COVID, and now suddenly there was a gap. So it was like a free service, and we had to figure out ways by which overnight we turn it into an online delivery system. So this particular research used smartphone devices as the tool, and over several months, behavioral data such as call, text, frequency, mobility, sleep duration, etc. were collected. Researchers found that sudden increase in phone use and movement often preceded the manic episodes, because remember, they're doing the bipolar. Likewise, decreased social activity movement signals the onset of a depressive episode, right? The model achieved moderate predictive accuracy and highlighted the potential for preemptive intervention. So we are not twiddling our thumbs waiting for somebody to show up with an episode. We know, okay, looks like signs and symptoms are showing up, let's do something preemptively, right? Takeaway, smartphone-based monitoring offers a predictive edge in managing bipolar disorders and can guide proactive care. 2014, Wang et al. Did another study. This time they were correlating smartphone usage with stress, sleep, and academic performance. This study was done on college students, as you can see, student life study, and mental health of university students. Over 48 students were monitored for 10 weeks using an app that tracked their location, phone usage, conversation frequency, and activity level. Higher stress and poor sleep were reflected in more screen time, less movement, and less face-to-face conversations. That correlates, right? Higher screen time, meaning fewer face-to-face conversations. Stronger correlation was found between passive behavior markers and self-reported mental health scores. And what is the takeaway? That it's one of the first real-world validation that smartphones can detect mental health risk in non-clinical population. Now, we are not over here targeting mentally ill population. These are regular university students, but we can still have the markers and provide them preventative health care, right? There's a limitation that, of course, the nuanced expression, the sarcasm, all these humor, it's lost on AI. It doesn't get it, right? So there are limitations, but with limitations, this was the result. What are some of the conversational AIs that are presently being used? Wobot is the most common one, Stanford-based chatbot using CBT principles. It's pretty nice to use if you want to. I'll show you where to find it. Vajpeyi, it's an AI penguin therapist. It uses CBT and DBT along with certain ACT techniques, a little bit more, progressive version of intuitive AI, and Uper, which is a basically mood tracker, does NLP-based interventions. I'll just show you. This is Wobot. This is Vajpeyi. This is Uper. Yeah. Now all the mommies here would be like, dude, today I know something more about AI than you do. Yeah. Okay, risk prediction, how do we do that? So suicide risk, relapse, and hospitalization, these are three main areas that I've covered today. Example tools are Qventus. It's a predicted behavioral health crisis in hospitals using real-time EMR data to do these things, right? There's another app called MindStrong. They use phone typing speed and behavioral data to predict a relapse in mood disorders, right? So I think we can all understand if one is depressive, then maybe they're taking slightly longer. And because they have like a collection of data, then they can use that to predict. If they're really fast and they're switching screens, then maybe with this person who already is suffering from mood disorder, maybe a manic episode is surfacing. Facebook's suicide detection AI scan post and flag content in 2019, it indicated 3,503 wellness checks globally just in 2019. Stanford's radar study, which is pretty famous, 2022, uses smartphone data and AI to predict psychotic relapse before the onset. And this is pretty awesome because we know that if the medication is given early on, the prognosis is many, many times better. So that was quite powerful. And again, the limitation is false positives, because AI is not that intuitive yet. So a lot of things can be misinterpreted, causing unnecessary alarm, and consent and privacy matters are a concern because we don't know what is being tracked, for how long, and how it could be used other than therapy. So those concerns remain for all the AI tools, and I'll come to that in a bit. Virtual support, where AI is used as companions. Over here, it's like a 24/7 companion, right? Helping with loneliness, journaling, and emotional regulation. Tools, Replica, AI friend you can customize and chat with about emotions and existential thoughts. It's a chatbot, and it does give very apt responses, right? Tess, also known as X2AI, AI coach, which uses used in crisis response and health promotion and understanding populations. Tess was used in Puerto Rico post-hurricane, where they couldn't reach to certain areas, because of hurricane and so on. And human therapists were scarce too because of the large extent of what had happened. So they were not therapists, of course, the bots are not therapists, but they provide some degree of support. So that's better than having absolutely no support at all, right? And the clinical depth of the intervention is not as good as we would like it to be. Triage and prioritizing system, AI is used in healthcare to streamline intake, flag urgency, and help allocate mental health resources efficiently. What's being done? Some examples are IBM Watson for Psychiatry tool. It was discontinued in 2022, but the research which is done on it shows it was pretty influential. Then License AI used by therapists to analyze recorded session and improve the clinical documentation. Think of times that we are sitting on the laptop and typing the documentation, the clinical notes, the treatment plan. So this AI is very useful for that. Very expensive though, extremely expensive at the moment. Then AI-assisted triage in emergency departments, which these can be used for that. Help prioritize suicide risk patients based on predictive scoring from intake form, history, symptom keywords. AI-assisted triage in And limitation still requires clinical oversight because they are not therapists, they are just bots, which are assistants, and algorithms may be non-adaptive in certain cases. So we might misinterpret certain data which is being presented to us. The next one is facial recognition and micro-expression analysis. Over here, Ally, the virtual therapist, is pretty apt. Avatar therapist that reads facial micro-expressions and voice tone to assess the post-traumatic stress disorder. And then Affectivia that decodes the real-time emotional states and facial expression to understand how the person is feeling. Ally was tested by veterinarians suffering from PTSD in the US, and participants, they felt that yes, this is working. They had reduced social judgment because with the military personnel, sometimes it's very embarrassing to even accept that they might be suffering from PTSD. Both because of socialized reason and societal acceptance. So this was pretty apt. And facial analysis of AI had cultural bias, as they found, because like for instance, Asians might emote a certain way, Westerners might emote in a different way. So AI is still not able to adapt to the variety of that expression, so it had its limitations. Now, this is pretty important for us as adapters and users of AI in mental health, clinical and technical limitations. The first one, of course, is lack of contextual understanding. AI still doesn't have that emotional nuance that is required to do extremely high-level analysis of expression, and therefore they might misinterpret. So maybe if I'm not moving around much, it could be just because it's my week off, or if I'm emoting in a particular way, it might be because I'm really, really hungry or something like that. It could be easily misinterpreted. False positive and false negative, AI might flag mental health risk incorrectly, creating unnecessary panic in the families or person, and miss subtle signs which only humans would notice. And we all know that when you're in the therapy room, there's so much in between the lines, there's so much in the non-verbal expression that we read and understand and cross-check, and that all is lost with the AI. Data noise and interpretation, so digital behavior can affect the numerous non-clinical factors, work, travel, marriage, divorce, all those kind of things, right? Lack of diagnostic capabilities. The tools that I talked about, they're not really diagnostic tools as of now. Soon they might be, at least assistive nature. Right? They cannot relapse comprehensive psychiatric assessments, including the interviews that we do, history taking, observation. Again, the same nuanced understanding of mental health that we have is missing. User engagement and fatigue. Many users stop engaging with tracking apps and chatbots once the novelty wears off. So initially everybody's like, yay, let me use it. And then they also get worried about how this would be used, confidentiality concerns, and so on and so forth. So then they might also disengage. And algorithm bias, we all know that AI is a set of algorithms, a set of data pool, and if that's not sufficing, then there would be gaps, right? Ethical and privacy concerns are at the topmost of AI debate that's ongoing about various usage of AI, more so in mental health, because confidentiality is like a foundation of what we do. So informed consent, sometimes the clients might not really understand what consent they're giving, to what extent their data is being used, the fine lines, right? So passive data could be used in many different ways. Active data could be used in many different ways. Surveillance and support, constant tracking of behavior might begin to feel intrusive. I don't wear an Apple Watch. I just can't deal with it, that constant engagement. So I need to switch off my phones once in a while. And I know there are huge benefits, but even though I love AI, I use it, but I don't want a tracker on my body 24/7, right? So a lot of people are now becoming wary of that. Is that surveillance or is that support, right? Data security and ownership, who owns this data? When can I withdraw my consent? And after withdrawing my consent, what data would you have and how would you use it, right? Stigmatizing and labeling, AI can flag somebody based on behavior patterns who might face stigma or might face judgment or discrimination. Legal liability and accountability, we could write a whole chapter on it because of so much gray area. What kind of data is being collected, what it is being used for. I don't know if you've noticed, sometimes we are talking about something like I want to go to Sephora and your phone would immediately show you an ad on Sephora. How creepy is that, isn't it? So that kind of tracking can happen with mental health concerns too. Then erosion of human contact, we already know, especially the younger generation, the digital natives, they're on phone 24/7, and it is becoming more and more challenging to onboard them in real life conversation, face-to-face interaction, learning the culture, learning the language, and AI is going to further reduce that, right? So that's definitely a concern. So all in all, the key insight, it's great, it's not bad. So let's not be aversive to it, but let's use it as an assistant, not a therapist. It can augment our work, but not replace us, thankfully. And it will not yet understand the complexity of therapeutic alliance that we have with our clients. And with that, I rest my case. Thank you. Thank you.